Thank you. All right, so now you can see here that there are two key facts that kind of frame this discussion. According to the Joint Commission Center of Transforming Healthcare, the root cause of most healthcare injuries and errors is not related to the array of healthcare technology, equipment, devices that our patients are exposed to, but rather the Joint Commission published in recent literature that an estimated 80% of serious healthcare errors involve miscommunication between healthcare providers during the transfer of their patients. Okay, so now we park that fact one and we go to the second fact that you saw here today. Last month, the AORN journal referenced the results of a separate but what I think is a related study that was conducted by a group by the name of MetSun. Now this was a review of a study of all malpractice claims filed with the National Practitioner Data Bank from 1990 to 2010, so it was a 20-year study. So now this study concluded that 80,000 never events were reported with the National Practitioner Data Bank during those 20 years. Now for the record, a never event is defined as an event that results in either death or a significant disability. So now we do just quick math, and the conclusion of these two facts results in 80% of these 80,000 events translates into 64,000 deaths and significant disabilities that were caused by miscommunication by a patient's healthcare team. Okay? Now this is not okay. We in the healthcare community, we have to be more diligent and more resolute to end this trend. Okay, so you've asked me to kind of give an overview of the aspects related to that, and that's what I hope to do today for you. Now, as a healthcare policy and regulatory specialist, my professional life intersects with miscommunication errors really in two ways. One is preventative in nature, and the other is retrospective. Now, first, to prevent miscommunication errors for my healthcare clients, my role is to assist by being on site to assess their existing communication systems. While observing documentation practices, while observing staff-to-staff communication, I'm able to identify any communication barriers and educate these patient care providers on the associated risks of those barriers. You see, knowing the why is very important. Okay? I also help my healthcare clients to develop stronger, more reliable communication exchanges based on the findings of these observations that we do together. So that's from the healthcare perspective. Now, conversely, for my attorney clients, my role is to retrospectively analyze case documents to help identify any sources of miscommunication that may have led to a healthcare error or injury. So I do that by first assessing the complaint, the legal document complaint. I then determine, based on that complaint, what documents need to be produced for me to review. When they are produced, I review these documents related to medical records, policies and procedures, human resource files, medical staff bylaws, even deposition transcripts. So now once all of that reading is done, I have to synthesize and integrate the relevant information from these documents so I can establish, is there a correlation between the hospital-acquired injury or any forms of miscommunication amongst the patient care team. Now, I apply this approach whether it's for the plaintiff or the defendant. It is the same analytical process. It should also be noted that whether I'm wearing my hat in a hospital or doing this for attorney clients, my opinion is not for sale. Now, you've asked me to dig down a little bit deeper today on the causes of so many communication errors in healthcare today that may or may not be at the root of many patients becoming injured as a result of miscommunication. Okay, so for members of the legal community who might be viewing this, it's best to begin by them understanding that there's three potential sources of communication within a healthcare organization. Now, and how they either independently or combined together could in fact likely lead to a patient becoming harmed or injured. Okay? So these three main communication systems or methods that are in play in virtually all hospitals that are mission critical to the delivery of safe care. So first off, we have policies, procedures, medical staff bylaws, rules and regulations. These are the guiding principle documents that define what the goals of the organization's performance are. Secondly, you have medical record documentation, which is obvious. Thirdly, we have person-to-person communication, where the exchanges take place amongst the caregivers as a patient is transitioning through the course of care. So those are the three main ways. So let me kind of break those down a little bit. Now, the first source of communication error centers on policies and procedures. Those in healthcare, they recognize that the governing board and the executive leadership team, they hold the ultimate responsibility for assuring that there are written policies and procedures to accurately be written, produced, and disseminated to the right people at the right time, obviously for the right reason, right? So now those specific policies must be communicated to all hospital staff during orientation, education, competency exercises to make sure that they apply those policies and principles to their specific job description, okay? So my role is to assess in any legal matter is to make sure by reviewing those documents that they're accurate, that they're complete, and the effectiveness of that policy and the communication tool meets the intended purpose. Okay? I do that part of the analysis to come to a conclusion on really the first core question that's on my mind while I'm performing the analysis. Is do these documents communicate all that is needed to be communicated to prevent acts that may reasonably result in patient harm or injury? Okay, so that's sort of the policy piece. Also, as part of the role that I play for the attorneys on doing some legal case work, is to review human resource files of any of the staff members who might have been either directly engaged or on the periphery of an event that might have harmed a patient. And I review those documents so as to make a determination to find, is there evidence of staff training that it was accurate, it was complete, it was team-based, to also get a shape of, we have the documents, did it get into the minds of the right people at the right time? Okay? So, I've been doing this for like 28 years. It's been my experience within hospitals and for the legal community trying to help out on some cases for approximately 10. And I have made the observation that policy communication has been still evident more often than it really should be. So some of the reasons I find that many policies and procedures that you come across are either outdated or they're inconsistent with the practice that the staff members are using. Okay, so that's automatically an opportunity for miscommunication. The second vulnerability that I see in healthcare is that, pardon me, many times the hospital staff who should be receiving detailed information relative to their job description on these policies are not receiving that information in a timely manner. Okay? The last reason I find most commonly is that there's a gap between policy during the developmental phase. So that, for example, is if an organization decides they need to develop a policy on a particular topic or activity, and they will do so with the best intentions. What they fail to do sometimes is to go and assess existing policies on that same topic or activity and make sure that there is a congruence between those policy documents. Many times when that's not done, you may find that a new policy says, sequentially we should do A, B, C, and D. And had they looked at other policies on that topic, they would have identified a miscommunication or a disconnect that would identify that the proper sequence was X, Y, Z. So these are opportunities that we try to work with our healthcare clients when we are on site, myself and my team. So that kind of covers the policy and procedure aspect of where miscommunication might get its origin, so to speak. The second most common source of communication error is medical record documentation. Now, as I mentioned before, the governing board, the executive leadership team, they hold the ultimate responsibility to make sure that there are policies, procedures, as well as the selection and the implementation of the information technology systems that are going to be used to document patient care. Okay, so that's a given. It always starts at the top. Now, I referenced medical record documentation systems as plural, and I do that so that you'll recognize, or your viewers will recognize, that since 1990 or so, there's been an influence of the electronic medical record that has appropriately so, worked its way into our healthcare system. There's still a long way for us to go to get it more universalized and more functional, but by and large, the introduction of that electronic medical record yields most hospitals in our country today have what's called a hybrid medical record. So that being that some parts of the patient's medical record documentation would be in electronic form, in an electronic medical record, otherwise known as an EMR, and the remaining documentation is going to be in a handwritten chart, as it has been for almost 240 years, if you can believe that, since documentation of medical records began. So in terms of experience within the hospital standpoint, the miscommunication opportunities that I see very commonly is you've got 30 or 40 electronic medical record vendors. There is no universal aspect of what they all should look like, how they all should function. So occasionally you'll find an EMR which may be of decent quality, but that the electronic medical record fields where patient care staff document activities are not definitive, or they're not in alignment with the organization's policies. So for example, instead of an EMR documentation field that's built in to communicate that an order was made for preoperative clinical guidelines, okay, they may not have that field. So when the nurse goes into the EMR to capture the reason for an order that she just received, she might document verbal order. Now, this makes a difference, and this is what opens the door to miscommunication, because a verbal order communicates that the physician is aware of this particular order for a medical test. And that's not the case if, in fact, the basic reason that this test was ordered was in accordance with pre-op clinical guidelines. So you can see that the opportunity to start the process of miscommunication could be that simple as related to a small field within an electronic medical record. One of the most prevalent, the second most prevalent opportunity for miscommunication regarding medical record documentation is that, again, there's no universal balance that exists. Some hospitals, 90% of the medical record documentation will be in the EMR, and 10% will be in paper. Another hospital, it's going to be a 70-30. But what I have seen is that there's so much attention being paid to training and to resolving and getting comfortable with the electronic medical record that slowly patient care staff are placing more emphasis on the EMR than they are in the patient care record. So pivoting back to what the Joint Commission promoted, that 80% of miscommunication errors involve at the time of the patient transfer takes place, patient care staff need to understand that when a patient is changing caregiver or when they are changing in the care setting, 100% of the record has to be reviewed. And that means looking at the EMR and the patient's paper chart, so to speak. Okay, so that brings us to the third most common source of this miscommunication error, and that's person-to-person communication. So during the course of myself or my team, when we're on site, we will gather key leaders from the organization and we will do tests. They call them tracers, whereby together we will observe the process of handoff communication by observing the documentation and watching the face-to-face communication to make sure that it is accurate, that it is complete, and in alignment with the hospital's goals to make sure 100% of the correct information goes with the patient when they are handed off to the next level of care. Now, most organizations have adopted what's called an S-bar methodology, whereby the following key elements are communicated in writing and they're communicated verbally amongst the care team members. So S is for situation, B is for background, A is for assessment, R is for reassessment. So now, when we're serving the clients, we will observe these use of, if this is the case, that they have an S-bar methodology in place. Are they using it correctly? Are they answering all appropriate questions? Do they provide the recipient caregiver the opportunity to pose questions before they leave? We take that information and we use that as an instructive opportunity for education with the patient care leaders as well as the patient care staff as best as we can. So that's sort of for the hospital side. Now, for the work that I do with the legal clients on communication, the first thing I will request if I suspect that there may be a miscommunication at the cause, potential cause for an error or an injury or harm to a patient, is to request the hospital's communication policies, which there may be multiples. I'll ask for all the documentation forms on how staff have been trained to document communication during the handoff process, either verbally, in hand, or in the electronic medical record. Okay? I then review the entire medical record to look for the evidence of the communication that should have taken place at that time. So lastly, I guess, many times patient care providers who are on the periphery or are engaged in the patient's harm, they may be deposed. If that's the case, I will in fact review their deposition transcripts so that they can, so that I can understand better, what they told, when they told, and what information was communicated to the additional caregiver. Okay, so I guess in summary, it's fair to say that the 80% rule of serious healthcare errors being caused by miscommunication has in fact been the case in my experience working with hospitals. And it's a trend that we really do need to reverse, and I'm trying with my team to do the best that we possibly can. So I want to thank you for offering me this time today. If any of your viewers are interested in any clarifications or need additional information, they're welcome to contact me directly here at my office. My name is Garry, and I'm here to help.